Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. It is the last Tuesday in July, and that makes it Top 10 Tuesday. And today we are going to focus on coding. So I have had a last couple of months of some challenging coding questions and scenarios. And this is a really good time to talk about some of the burning questions out there. So we're going to really get into some interesting items, everything from some ICD-10 questions in orthopedic to some ER questions on critical care. I've got some things on transgender coding that came up, and then some things on stroke. So we have a lot to cover, and we want to make sure that we can hopefully speak to some things that we haven't talked about before when it comes to some of the coding questions. So let's get started. So a couple of things that we want to look at in spine, and spine has been a challenge for me lately because I'm dealing with a lot of specific disorders and some confusion when it comes to some of the complications out there, and really how to kind of go through your ICD-10 book and understand not only what your physician has given you as far as reporting, but also how to send to the payer something that's going to allow for not only a diagnostic service, but also possibly a procedural service. So a couple of scenarios. First one is, Terry, this is a 55-year-old patient. They were diagnosed with posterior lumbar disc disease of 2 discs along with radiculopathy. To correct this condition, he underwent a partial excision of the 2 lumbar discs, followed by a posterior lumbar spinal fusion at L13 with a back cage. That's a Bagby and Cullett's cage. They're always called something, proper nouns. And then an interbody fusion device. What are my ICD-10 CM options? So we know that's diagnosing options is what the question is asking for. So for this patient, you want to code the M51.16, and that is the intervertebral disc disorder with radiculopathy in the lumbar region. So let me break it down for you. The M51, that's the thoracic, thoracolumbar, and lumbosacral intervertebral disc disorder. Then you have to add a digit, so now you have to get to 4 digits, which is M51.1, thoracic, thoracolumbar, and lumbosacral disc disorder with radiculopathy. And then the 6th one, so the 5th digit, which actually ends in the 6th, is the M51.16, intervertebral disc disorder with radiculopathy lumbar region. So it's basically you're building on with more information as you continue with the coding scenario. And then number 2 says, Terry, I'm not understanding the difference between spinal cord versus peripheral spinal nerve. From his ICD-10 CM perspective, can you give me a simple explanation? Okay, so getting a simple explanation from spine is tough, but let me see what I can do here. So a diagnosis of myelopathy, spinal cord involvement, that's a more localized in the spinal area as described by the patient. And then radiculopathy, nerve root involvement. So that's why you have symptoms of pain and numbness going down a lower extremity or leg with root pain. So where it started from. So hopefully that was kind of a simplistic answer, but you can kind of visualize what's going on there. Number 3, Terry, CPT codes for epidural injections, 62320 to 62323, performed to relieve back, neck, and extremity pain due to compression of spinal nerve roots caused by HNP. Can you explain again what HNP is for a new coder trying to understand? I know you have a clinical background. Okay, so we need to go back to basics for this one. The intervertebral disc is comprised of 3 parts: the nucleus pulposus, NP, which is the mucoprotein gel located in the posterocentral portion of the disc. Surrounding the NP, again, that nucleus pulposus, is the annulus fibrosus, the AF, concentric laminated bands of fibrous tissue. And finally, they call it cartilaginous end plates separate the disc from the vertebral body. So HNP is herniated nucleus pulposus, and this occurs when the NP herniates through the AF, the annulus fibrosus, usually in a posterior or posterolateral fashion. So they talk about that in an up and down fashion. This can occur this only can occur when the AF is disrupted either by a violent trauma or recurrent mycotrauma. A history of trauma has been elicited on over 50% of those with lumbar diagnosed HNPs, and I got that from the American Academy of Orthopedic Surgeons. Also, studies now show that HNP is about 80% lumbar. So in even more specific terms, it is the herniated core of an intervertebral disc, so the nucleus pulposus of the disc, and can cause pain and or neurological symptoms, and they compromised of either mechanical compression, inflammation, or both, especially because it comes in contact with the nearby nerves. So the epidurals, what they do is they try to relieve some of that pain by filling those gaps with that medicine. And you also see sometimes that epidurals also perform for spinal stenosis due to osteoarthritis, very similar. Okay, so number 4, I like this one. This one cracked me up, actually. So it says, Terry, my boyfriend and I are NFL fans like you, but he's a Raider fan, and I'm a Kansas City fan. He's a Raider fan? Poor guy. He's been kind of rude lately about my team, so I grabbed my football and threw it at him in fun, and I hit his face. Well, it left a bruise on his cheek. He wasn't happy with me. He came into my office for treatment. Is there a code for this? Yeah, I know what you're thinking. So I'm trying not to laugh, Shelley, but yes, there is a secondary code for the injury part, which is what you're asking for. It's W21.01XA. You need a 7th digit for the encounter, and that is struck by a football initial encounter. So I'm not sure if that was the intent of the code, but that's what it is. And since it's a long season, I would keep in your back pocket W21.01XD. That's a subsequent encounter. You never know. So as you know, I'm a Steelers fan, and so I probably would have thrown the same football at a Raiders fan. You know, they've been talking smack lately. So, but hopefully you guys are less violent now as you watch the games together. Okay, so number 5 is a question that comes up regarding prescription drug management. And this question involves a little bit of discussion because a lot of people, I should say a lot of providers, are trying to use prescription drug management as a blanket statement for a moderate visit. And as part of the medical decision-making of a visit code, and this is part of the question, it says, the physicians think they add a medicine or a refill of a script, and they can automatically code a level visit under moderate, meaning a level 4 visit. So please help me by clarifying the use of prescription drug management as part of their support of a level of service if you can. Okay, Anna, if you place 4 auditors around a table and place a typical established patient visit in front of them, what tends to follow is a scene that resembles less about building a consensus and more along the lines of a comedy show with everybody kind of falling down laughing because nobody has the right answer, or there's not, again, a consensus of what is the right answer. So perhaps no one area is more contentious and liable to lead to such a scene as a simple 3-word phrase from the table of risk, and that is prescription drug management. So back in the day, E&M guidelines, so many physicians interpreted this small, unassuming phrase as their invitation to increase the complexity of simple visits based on the prescribing of any medication. And then, of course, with every new generation of auditors coming onto the scene, this myth seems to reappear and propagate a new problem. So let's look at the definition first. A definition of these 3 words as it applies to the E&M guidelines needs to be found and understood. So in general, prescription drug management can be any one of the following: writing new prescription, reviewing but not changing prescribed medications and dosages, discontinuing an existing prescription and why, or a decision not to add new medications to the current drug regimen due to potential harmful side effects or interactions. So the duration of the prescription drug regimen is not taken into account when applying these factors to the table of risk. But the problem with jumping forward with moderate complexity under medical decision-making based on only the strength of the prescription drug management becomes a question of acuity. The table of risk is but one of 3 factors that determines the medical decision-making. And in many cases, the category of the problem necessitating the visit will be the determining factor for the medical decision-making. So as an auditor myself, it usually comes down to the decision regarding whether a presenting problem is self-limiting or minor, or a new problem to the examining physician with no further workup planned. So a patient can present with 2 minor problems and the medical decision-making still falls under low complexity. So the auditor must walk a fine line between making a sound auditing determination and leaving it up to the physician to paint a clear picture of the acuity of the patient. So there are going to be times when the presenting problem reaches the acuity of, let's say, a 99214 or a 99204, but the documentation doesn't support it. So conversely, there will be other times when the presenting problem appears to be minor, but the physician's documentation points to a more complicated condition. So in the end, if the documentation is not pointing to one clear final answer, you're going to have to query the physician. So while it is tempting to defer to a higher level based on the fact that physicians go through years of intense training to become doctors, different physicians will have different comfort levels when it comes to measuring patient acuity. So prescription drug management may look like a surefire level 4 on paper, but in questionable cases, the physician is the best judge of acuity. And also, I'd like to see more than just a list of medicines. If that's all I see, that goes into the past medical history, because I want to know if you're changing medications or if you're just saying status quo, let us know why. You have to give some kind of detail in that area for that to be one of the components of medical decision making. So I hope that helped, but this has always come into a problem. It always has. I've got a dermatology group right now that will give a patient a what do you call it? I just lost my train of thought. A sample on a rash or something, so a topical medication, and then they will say, "Oh, this is a level 4 service." And I'm like, first of all, it's not a prescription because you gave them a sample, and next, it's not management. You said use this till it's done and PRN as long as your rash goes away. Management is the key. Think of those of you who are managers. Think of being managed. It means that it's an ongoing process to make sure that the interactions between the drug regimen of this patient is where it should be, so that there's not going to be any toxicity, there's not going to be any interactions that are counterproductive or harmful side effects, and that the patient is taking their medication as prescribed. So if that's not part of the detail of the prescription drug management, then that's not what that is. And so just be aware of that you have to really fulfill the definition of the actual service. Question number 6. After a level 3 E&M service for a new patient with a left forearm pain and an MRI of the left arm, the physician diagnoses a bone bruise in the forearm. What exactly is a bone bruise, Terry? Because I didn't think a bone could be bruised. And this is from a Seattle, Washington client. Okay, so yes, bruises can penetrate the surface of the skin, and the effect of the subcutaneous layers all the way down to the bone. This is now considered a bone bruise caused by a traumatic injury. And this came out from a research study in University of Rochester Medical Center. It's less severe than a bone fracture, but a bone bruise may also be called a microfracture by some physicians, so look for that in the report. So you have your 7328218, that's for your MRI. You've got probably your LT modifier for the left side, your 99203. You might need a 25 modifier to designate this as a significant separate service from the MRI. So your diagnosis code, the S50.12XA, contusion of left forearm, initial encounter. This is for the bone bruise. So you might think of a black and blue mark on your skin when you hear the word bruise, but bruises can also happen in muscle and bone. And this happens when an injury damages small blood vessels and cause the blood and fluid to leak into the nearby tissues and blood vessels. That's where you get the color from. Deep inside the bone is an area called the medulla. It contains the bone marrow and fibrous tissue called the trabeculae. With a bone fracture, all of the trabeculae in the region of a bone that has broken, but with a bone bruise, an injury only damages some of these trabeculae. So diagnosing these type of injuries, it's kind of interesting because you really can only diagnose it with an MRI. A CT scan is looking more for joints and fractures and things that are hidden. The MRI is looking for things because of dealing with the proton imaging. They're looking for things other than joint. And so looking for, areas that aren't necessarily broken but are damaged. And so that's the difference there. So hopefully that was explained in the way that you can kind of understand what's going on with the bone bruise. So I've got another one. It says, Terry, quick question. This is number 7, or they say, or not so quick question on critical care time. I just did a Talk 10 Tuesday on this on the ICD-10 monitor. So it was kind of interesting. So this one is an interesting question and convoluted. And this is one from one of my ER physicians that I have in Arizona. He says the first hour of critical care time obviously is 30 to 74 minutes. One of my colleagues always seems to document 22 minutes, and then the physician in our same ER group comes back to provide critical care services on the same patient, same day, and it does add up to past 30 minutes. So I thought you could add up all the minutes to get to the 30-minute threshold if the doctors were in the same group. But one of my mid-level providers is telling me that only the first physician can total the first 30 minutes before you can add on any additional 30 minutes. And if they don't total first 30 minutes with the initial physician, then you can't code critical care at all. Okay, so Dr. Johnson, here's what I'm dealing with here. So I'm going to add a little bit to your confusion, but you'll have some references here to support your position. So the CMS transmittal R2997CP, it states CPT code 99291, the initial critical care time, billed as 99291, must be met by a single physician or qualified NPP. This may be performed in a single period of time or be cumulative by the same physician on the same calendar date. A history or physical exam performed by one group partner for another group partner in order for the second group partner to make a medical decision would not represent critical care services. Okay, so if you heard what I just said, you're like, what the heck is she talking about? Well, then you go into, so that was a transmittal that came out and they thought they were helping. But then you go into the Medicare manual section 30.6.5, and that says the CPT critical care codes 99291 and 99292 are used to report the total duration of time spent by a physician providing critical care services to a critically ill or critically injured patient, even if the time spent by the physician on that date is not continuous. Non-continuous time for medically necessary critical care services may be aggregated. Reporting the 99291 is a prerequisite to reporting the 99292. It also says physicians of the same specialty within the same group practice bill and are paid as though they were a single physician. Okay, so that kind of stuck with me. Then it goes on to say about critical care as a time-based service provided on an hourly or fraction of an hour basis. Payment should not be restricted to a fixed number of hours, fixed number of physicians, or fixed number of days on a per-patient basis for medically necessary critical care services. And then it talks about time counted towards critical care services may be continuous or intermittent based on aggregate time increments. So 50 minutes of continuous clock time or 5 10-minute block time spread out over one calendar day. So it's all what's added up on one day. Then it says only one physician may bill for critical care services during any one single period of time, even if more than one physician is providing care to a critically ill patient. So basically they're saying only one physician can really get paid for stabilizing that patient from a critical spot. So you would think based on what that transmittal says that it says must be met by a single physician or qualified NPP. But I'm looking at that language, must be met by a single physician or qualified NPP. Okay, wait, let's go revisit what it said in the manual. It says physicians of the same specialty within the same group practice bill and are paid as though they were a single physician. So when I read this, the rules are contradictory by nature. But if you look at the definition of single physician as it relates to payment in critical care captured services, I believe that if multiple physicians from the same group specialty on the same day document critical care time, it's additive. So it's all cumulative care, and if it exceeds 30 minutes, I would bill it as a 99291 and then any additional add-on codes. So I think you have enough support for that based on what I just gave you. Number 8, hi Terry, my PCP and alternative medicine clinic is starting to provide services for the transgender patient community. And I have some questions about a condition called gender dysphoria. Do you have any way to help me understand the diagnosis? Okay, yes, I've been doing a lot of research on this because I do have some clients now that are also providing services to that population of patients. So first we want to get a little bit of just some basics. So sex versus gender. So sex, the anatomy of an individual's reproductive system and secondary sex characteristics. So breasts, reproductive organs, etc. But gender or expression of one's identity, this is the performance, expression of one's identity, or either social roles based solely on the sex of the person, gender role, or personal identification of one's own gender based on internal awareness, gender identity. So you'll realize that this has to be diagnosed by a healthcare or mental health professional because there's something called gender dysphoria. And this is a diagnosis, again, from a medical professional when the gender assigned at birth does not match the gender from which individuals identify, and they experience significant distress as a result. That's where the mental health issue comes from. And I just want to explain. So according to DSM-5, which is the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, refers to this as gender dysphoria. So for a person to be diagnosed with gender dysphoria, there must be a marked difference between the individual's expressed or experienced gender and the gender others would assign him or her, and it must continue for at least 6 months. So it has to be very well documented. Now, how to transfer that to ICD coding. Transgender is an umbrella term used to describe individuals whose gender identity, one's inner sense of being, male, female, or something else, differs from their assigned or presumed sex at birth. So it's also important to note the DSM-5 states, that gender nonconformity is not in itself a mental disorder, but the critical element of gender dysphoria is the presence of clinically significant distress associated with the condition. And in children, the desire to be of the other gender must be present and verbalized. So gender identity disorders in ICD-10 start at the F64 code series, and you're going to need additional digits, a disorder characterized by a strong and persistent cross-gender identification, such as stating a desire to be the other sex or frequently passing as the other sex, coupled with a persistent discomfort with his or her sex manifested in adults, for example, as a preoccupation with altering primary and secondary sex characteristics through hormonal and manipulation and surgery. So codes F64, the F64.0 starts with transsexualism, and it goes down to F64.9, gender identity disorder, unspecified gender dysphoria. So that's the area you're going to look at, and just make sure you do a lot of research on this before you start labeling patients on this, because it's definitely causing some confusion within not only payers, but also in medical clinics. Okay, number 9 says, Terry, after we spoke last week about how we are coding our stress echoes at our clinic, you said that we should have been coding 93351 CPT code, and you asked me if we were using any kind of contrast in the office like Definity. I had no idea what that was, so I just did an audit for our stress echoes and realized that yes, we have been providing it, but not billing the add-on code 93352 as you said we should have been when Definity is used in a stress echo. Now, it's only about 14 patients so far that I've found. What is your advice for billing the 93352 because it's not on the patient's report? We do have documentation in our medical records that Definity was used, but it's not on the final report. It just shows the amounts were used and a list of patients. And can you point me in the right direction where I can try to rebill this? Okay, you're not going to like my answer on this, but because it's not in the patient's report, you can't then go back and recreate it. You can try an addendum, but it's going to be really hard for the payer to say, okay, I'm going to be able to pay for that. Also, if you were billing the 93351 to begin with, which is the stress echo code procedurally, not the contrast, and you were already paid, trying to go back and pick up an add-on code when you have no base code to add it onto, you're going to have a problem. So what I would recommend is either you do it as a batch and contact your provider relations department and ask them, okay, what can I do here? Because I have 14 patients where we use Definity and I need to get that paid for. And then, and also the medicine if you're in your office. But if they don't allow it because you've already gotten paid for the stress echo without adding the add-on code, it's basically now you're going to have to move on from this point and now add it on. So there is a way to do it, but you're going to have to get a buy-in from your payer. So hopefully those 14 patients, you have some have similar payers so that you can send them as a batch. But that's the best I can direct you in that scenario. Number 10, Terry, I know you have a clinical background, so can you explain what a hemorrhagic stroke is, please? There are two types of stroke, I know, but I'm not sure the difference between hemorrhagic and ischemic. Okay, so hemorrhagic strokes are less common, and in fact, only about 50% of strokes are hemorrhagic, but they are responsible for about 40% of all stroke deaths from my information. So a hemorrhagic stroke is either a brain aneurysm burst or a weakened blood vessel leak. Blood spills into or around the brain and creates swelling and pressure, and that damages cells and tissue in the brain. And there are two types of hemorrhagic stroke. One is called intracerebral and one is called subarachnoid, which I'm sure you've heard those terms. My mom actually passed away of a subarachnoid stroke at age 49 in 1991, so I'm very clear on what those are. The ischemic strokes, now those occur when a blood vessel carrying blood to the brain is blocked by a blood clot. This causes blood not to reach the brain. So high blood pressure is the most important risk factor for this type of stroke. And that's why patients who don't know if they have high blood pressure can sometimes have a partial stroke, they call it, and don't even realize it. And ischemic strokes count for about 87% of all strokes. And that's where there's a weakened area, did not have enough oxygen for a while. So the areas, you know how some patients have strokes and they say, I can't lift my arm or my left side isn't working. It's because the oxygen wasn't there. So that part of their body forgets how to work. But patients can recover through physical therapy, occupational therapy, and getting medical attention as fast as possible. So those are your kind of your stroke informational tools there. Today's Top 10 Tuesday was also brought to you by Stranger Things, Netflix.com/Stranger Things, and Anesthesia LLC. ABC offers seamless physician billing and practice management software and services to thousands of anesthesiologists and CRNAs nationwide. AnesthesiaLLC.com. So today I want to end with my personal tidbit on the impact of social media, your job and your psyche, and your career as well. I'm starting to see more and more people thinking it's okay to post about their employer frustrations on social media. There was a teacher recently, and my daughter was telling me about this, where she didn't like her kids. She was subbing, and she posted on her Facebook page how her kids are awful and how she can't wait every day to go home and have a drink, and that she was joking and said she was even thinking of bringing a flask of vodka to school to get through the day. Okay, seriously, people, don't do that. On LinkedIn, just the last week, I saw a gal there that was there, and she was a healthcare professional looking for a coding job, just passed her AAPC exam for a certified coder, and she slammed the AAPC and other credentialing organizations saying, I passed my test and you didn't find me a job. Okay, one thing you have to know, it's not their job to find you one. It's their job to equip you with the tools that you have, like a coding credential, to sell yourself as a person of knowledge or possible experience, and hopefully likable enough to hire and where you fit. Stay off social media if you're someone that posts random thoughts that could get you into trouble. It's not going to serve you well in your job or your career. Also, remind your kids of the same. If they're up for a scholarship or a competitive college position or a job or an employer, they can search them out, even if they're a private account. I've seen it. And so only positive thoughts, uplifting acts of kindness to others. And let's face it, the realities of social media, it's not always reality. So some of the postings are not actual reality of someone's life. They're actually more either what they want it to be, or it's just kind of an anomaly of what they post. But you have to be careful. Social media, to me, it was a great thing for when, I have cousins in down under in Australia, and I have a huge family in England and Ireland. And so it was nice to be able to contact people and talk to them and see photos of their life and them, reciprocate effort because we didn't see them. But then social media became this huge phenomenon, and it's kind of a pain sometimes. So just be careful with that. Now, what you'll see on my social media posting, if you go there, just in case you're wondering. So on Instagram, that's kind of my personal Facebook. I mean, I get on Facebook once in a while. I don't like it, but Facebook bugs me because I see things about certain people in my family that I'm not really happy with. And certain people that I'm like, okay, I don't need to know that. And so I try not to get on my personal Facebook too often, but my my Instagram personal stuff is also kind of a business personal. I do promote the podcast on there, but we are in, my family and my friends and my circle of people, we do like fine dining and we like traveling a little bit, and we just like some local events. And so you'll see that up there too. So If you like music and things like that, you'll see that up on my story and sometimes on my page. But I also like posting thoughts of the day and just some uplifting quotes, because sometimes that can just give you that Monday motivation, or they call it the Wednesday wisdom or Throwback Thursday. So there's all kinds of different hashtags just to represent what you're feeling on that day. But it's always positive. Rarely do I post something saying, I have a client who's a big pain in the butt today and I really wish that they would just go away. I don't do that. I just tell you guys that. So, but I try not to do that on social media. My Twitter, TerryCoder1, that's only where I put in healthcare postings that you may like. I retweet some things. And then I also post my CodeCast there every week. So you'll see that on there. I also have a couple other Twitters, one for the Bun Life, which my daughter and I are recreating. And hopefully that'll be up soon. I know I keep promising it, but with her schedule and my schedule, we have 2 episodes. And now we're trying to figure out the music thing and all that. So we are getting that up. It's really fun. We're having a ball with it, just relaunching that and everything. But I also have a Twitter for my sports news articles and podcasting. So if you like that, Terry in SoCal IF, so CALIF. That's for my Steelers stuff, and I post all stuff sports on there. But I always make sure it's professional. If you like an occasional rap song, I know I always try to shout out my music producer when I can. Then if you don't like it, it's not for you. But some once in a while, I do like to put that out there. I blame it on him because I never liked that kind of music before. But he got me to like it, and so sometimes I'll put that out there. But there's some things on there that you just want to really kind of take note of. If you are on social media, just know there's nothing called private. Somebody has access to it. They just do. How many times do you go to make a plane reservation because you want to go to Hawaii or go to Las Vegas, and then you pull up your email just to check email, and all the ads on your email account is all about your plane ticket you just tried to buy. It's creepy. There's people out there that can see everything. So just something to keep in mind from things I've been seeing in the last week or so. So be careful out there when you're dealing with social media. Okay, everyone. So make it a great day, a great week. And until next time, thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.